today. So today we're going to be talking about a wonderful topic near and dear to our hearts.
Nutrition in your neurogenic bowel. So we did give this presentation about a month ago, just to give some background to some other dietitians and clinicians because we are trying to, gather some information for other practitioners because it is such a hot topic that unfortunately for all of you is not, that well understood. So we did kind of tweak it a little bit so that it's a little more pertaining to our target audience. So we're going to focus more on what you can do to make some changes.
Right.
Oh, no, it won't let
I
you.
know.
All right, so we're going to talk a little bit about just general anatomy at first, which you all are probably very well aware of, but just to kind of focus in on what nerves specifically are contributing to changes in your bowel habits. So obviously a higher level injury like tetraplegia or quadriplegia is going to affect all of your limbs and is more likely going to affect your digestive system. Paraplegia can also affect your digestive system, but depending on where the level of injury is, it may affect it more and it may affect it less. So there are a variety of nerves that control your digestive system, and those more specifically here are T9 to L2 and S2 to S4, which control what we call peristalsis. We added a slide on what is peristalsis.
Okay, so just to do a little brief review of kind of normal digestion, normal bowel function. So basically, we eat food with our mouth most of the time, sometimes not with our mouth. Sometimes we put food directly into our stomach via a G tube. But then in our stomach, the food mixes with an acid to kind of start some of that digestion process. It slowly moves from the stomach into the small intestine. Then all of our nutrients start to be absorbed and broken down a little bit more in our small intestine. And things move through our system with the help of peristalsis, like Megan mentioned. We're going to describe it in the next slide. You can see it's kind of like a pretty intricate highway system in there, so it does need to be really pushed through the system. It's not just gravity is going to push it all the way through.
It's a city highway system.
Yes, it's a city highway. Yeah, lots of loops and turns. Our small intestine is where most of our macronutrients are absorbed. So that's our carbohydrates, our protein, and our fat. And then by the time it makes it to our large intestine, that's where a lot of water gets reabsorbed and fiber gets fermented, which is how we get some gas. And then finally, what is left is stool or poop, and that poop needs to come out in some way, shape, or form. So here's a little review of what peristalsis is.
It's really hard to describe.
It's very hard to describe. Megan was trying to use a tube of toothpaste which is a good analogy because like basically you need to push, like the muscles contract above and it kind of pushes the food through. So there's like this natural kind of muscular motion that moves through our entire GI system. So yeah, we can see our little ball moving through the tube.
We were really struggling with how to describe what peristalsis is, but basically if you don't have any of the contractions, the food is just going to sit there. So you do need to have the muscle contractions to push things along.
There's actually in the pilot episode of Seinfeld, he mentions peristalsis, and I was trying to find a way to put that into this presentation, but it wasn't working. So I highly recommend you go check out the pilot episode of Seinfeld.
It's a very niche Google search right there. Okay, so we talked about normal digestion. Now, what is neurogenic bowel? Basically, this really just means that there's a loss of normal bowel function because of nerve damage.
And as Megan mentioned in the first slide, when we were talking about the normal spinal cord anatomy and kind of what controls our bowel system, S1, S4, that's at the very, very bottom of our spinal column. So almost every individual that has some sort of spinal cord injury or disorder ends up likely having some sort of impact of neurogenic bowel, just because those nerves are literally at the very, very bottom of our spinal column.
But there are a few different types of neurogenic bowel, and like Olivia was mentioning, maybe like different degrees of what people experience. So the two different types that we see here, spastic or reflexic. And I tried to give you a visual of this angry face because it's an easier, we're very visual people, right? So basically your digestive system is kind of angry. It's got increased tone. It's like when you're really angry and you're clenched up, your digestive system is just like that. And how it increases with like increases incontinence is that you're so clenched up, and then if you have like a spasm or something, it'll just cause some of those contractions similar to peristalsis and push the poop out, basically. On the other hand, there is flaccid or areflexic, which is the opposite of spastic, where your body is just kind of loosey-goosey. So you have decreased tone and you have difficulty having a bowel movement because, like we just mentioned, you need to have those contractions in order to move the stool out of your body and move it through your digestive system.
So interestingly, like there is technically like a diagnostic process that can go into like diagnosing neurogenic bowel. I think a lot of people, after we have a spinal cord injury, we kind of most of the times know to a degree. But then I do have some individuals who maybe, weren't born with neurogenic bowel, but then because of like cerebral palsy progression, muscular dystrophy progression, they end up acquiring neurogenic bowel. And that's really where we need to make sure that we are making an appropriate diagnosis. And it kind of is it's not a very invasive testing that needs to go into it. We're really looking at symptoms, frequency, urgency, whether or not someone is having incontinence and how much. There's also often a physical assessment where we're assessing tone, reflexes, and distension. Specifically, when we're thinking about tone, we're thinking about like tone of like the area surrounding your anus.
Mhm. So it is a part of, like, the physical assessment is a part of the ASIA exam usually, which they'll do on an inpatient basis. But you'll notice on the left here, like the symptom assessment is more subjective, and there are some subjective tools that I really don't think people are using all that often that are looking at quality of life and how your GI symptoms are affecting your day to day. And I think that's what we're really trying to focus on is how can we alleviate some of those symptoms so that it isn't affecting your day to day.
So just a little bit more in brief, like the different things that can cause neurogenic bowel. I would say a lot of people in this group, we may all have maybe a spinal cord injury disorder, but it's not necessarily coming from the same place or the same etiology. Some individuals have a surgery and that results in neurogenic bowel infection, accidents, spinal strokes, spina bifida, cerebral palsy, multiple sclerosis, nerve damage, which can result from diabetes, because diabetes, when it's left uncontrolled, can result in damage to our nerves. I think we most classically think of like people no longer being able to feel their extremities. But I think that, as some of our practitioners have pointed out, if you already have a spinal cord injury and then you also have diabetes, we're maybe not necessarily getting that as clear of a sign that we have some of those nerve damages. Also, just general stroke, brain injury as well. Both of those can result in neurogenic bowel. So big wide range.
So we should be talking about
Yeah.
it more and more. All right, so what is a bowel program? It's really, we summarized it here. Like it should be conservative. We're trying to use as few interventions as possible. It should be comfortable and realistic. We're not trying to change your entire life. And as I mentioned, it should improve or maintain your quality of life. Hopefully improve.
Okay, so the goal here is to establish a scheduled time. We say each day, but sometimes people end up going to an every other day schedule just because they're finding that a daily schedule is not the most effective for them.
Or twice a day.
Or twice a day, even. Yes, you're right. Establish a scheduled time to stimulate the complete bowel evacuation to prevent incontinence and constipation.
That's like the Merriam-Webster.
Yeah, this is the Merriam-Webster definition.
Although I don't think bowel program is in the dictionary.
No, it is not. But we're talking complete bowel evacuation. I think that sometimes I have some patients who come to me and they're struggling because they maybe are experiencing incontinence at other times throughout the day. And sometimes incontinence is happening because the bowel evacuation was not complete. Like we really didn't get everything out. We have a lot of different interventions that we can utilize. We have our meds, We have some positioning exercises, timing, and then also our favorite, which is nutrition. We need to consider kind of your general pre-injury bowel frequency and timing. So, like, if you were someone who woke up every day, had a cup of coffee, and went to the bathroom every day of your life before your injury, me?
I'm just kidding. It's really not you.
We need to consider like, oh, I was someone who literally went to the bathroom twice a week. We're not going to expect that you're magically going to be able to go every single day after an injury. We need to consider the type of neurogenic bowel. Is it the spastic or the flaccid? Because that can determine some of those more medical interventions that we can utilize. And then kind of looking at what your individual preference is. Like, would you prefer to be going like as non-medical interventions as we can? Would you prefer to kind of make it a little bit more like, I kind of just want to take the pills and do some things to adjust that way? We want to take into consideration timing, like which time of day do you have caregivers, which time of, like, are you someone who likes to go to bed at 1 a.m. and then wake up at, 11 a.m.? If so, you're probably not in this class.
Just waking up.
So those are kind of our big considerations that we need to have throughout this whole process.
So I think to summarize that slide is like there are a lot of things to consider. We're trying to make it as simple as possible with this presentation, but it's not always simple. So what does our stepwise process look like? Obviously, first we need to know, do you have neurogenic bowel and what type? Are there any barriers? What level of function do you have? What about like medical knowledge? Then we're going to try to design a bowel program, starting with pretty non-invasive options like diet changes. But we also want to take out anything that might be contributing to some of those barriers. We might need to tweeze out, like, is it actually areflexic versus reflexic? Because it's hard to actually pinpoint which one. And then continue to check in and assess the environment and just kind of, things are not going to be the same forever. We all know you travel somewhere, you're constipated. You have a holiday party, you're constipated. I don't know.
Or not. If you have Chinese food, you're not constipated.
That's true. Or like you just like forget to drink enough water one day and then it throws you off for a week. Like it's not going to be perfect day in and day out. But today we're going to focus on designing a bowel program. And starting with nutrition, obviously, because that is our expertise.
This is our job. All right, so we have to talk about fiber. So basically there are two main types of fiber, soluble and insoluble. We're going to try and use some alliteration to help us remember these things. Soluble fiber makes our poop more solid. If we think about making oatmeal, I made some oatmeal this morning actually. When we make oatmeal, the oatmeal absorbs all of the liquid that's in the pot. That oatmeal in our GI system is still doing the same thing.
Acts like a sponge. It's another S word.
So it's really absorbing everything as it's moving through. It can make things a little bit more solid.
Soluble, solid,
yep.
Sponge.
Yes. It's not to say that these foods aren't foods that we should be incorporating, because actually a lot of our high soluble fiber foods help to manage not constipation, cholesterol. Because when they're absorbing liquid in our GI system, they're also pooling some of those free-flowing fluids in our system, which can include cholesterol. So it's a very useful thing to incorporate for that reason. But just maybe being a little cautious. Maybe oatmeal every day is not really the vibe for maintaining that active GI system.
And if you know us from any of our other talks, you know how much we
love oatmeal. We love oatmeal.
So we're never going to say don't ever eat it.
But more just be aware, right? Like if you're coming to this presentation because you've been really having a tough time with your bowel program, you're like, oh wow, I've been eating oatmeal every day
with a banana.
With a banana in it. Those are particularly two of the highest soluble fiber foods, and probably the ones out of this list of soluble fiber foods that are the most aggressive, or the ones that people really identify as like being problem childs. I will say that the soluble fiber foods tend to be the ones that we think of as like, oh, this is what I would eat if I was sick. Like I would have oatmeal, maybe some banana, applesauce. Um, those are more of our sick day foods. But these can be really helpful if someone's having issues with more loose bowel movements. If you have an ostomy and you're like, oh my gosh, the output is just not the consistency that I really want it to be, then it's like, okay, we need to incorporate more of these soluble fiber foods. A lot of foods are a mix of the two different types of fiber. That's why we have to give a special shout out to the bananas and the oats because they're a lot more soluble than they are insoluble.
And I also want to add to like here we're talking about like thinking about what type of bowel movements you're having. Should have put an image of the Bristol stool chart, maybe at the end. Um, but in general, like you want to be eating fiber, and it's really helpful to kind of tweeze out like, are you responding more to banana or oatmeal or some other types of food? So it does take a little bit of trial and error.
I will say in general, we do want to be shooting, for healthy individuals to be having 25 to 30 grams of fiber per day, which is no small feat. Most foods, even our high fiber foods, are going to be like maybe 3 or 4 grams of fiber. And that's okay. I think that one thing that's been happening recently is there are a lot of food products that have added a lot of fiber to them. And I've even seen food products that even have like 30 grams of fiber in one food. And then people are coming to me saying their stomach hurts.
Fiber One bars.
Yeah, the Fiber One bars. We've all been there. But that's just a lot of fiber in one sitting, right? Like if we think about our natural sources of fiber are going to be giving us like 3 to 4 grams, and that's considered a high fiber food. If we're getting all of it all at once, it's really just very aggressive to our GI system. We may experience more gas, more bloating, because fiber is truly never going to be fully digested. We eat it so that we can poop it out, basically. In general, it helps to move things through our system and make sure that we have enough content to be going to the bathroom.
Do you ever think that like cavemen must have had really regular bowel movements?
No, they probably didn't because
But they were mostly eating roughage.
were they? I don't know what they were eating.
Roughage and meat.
Yeah, they were eating that.
Speaking of roughage, so we talked about soluble fiber, right? Solid. Oh no, what's our alliteration for this one?
Insoluble?
Yeah.
There's no.
Okay, so we have alliteration for soluble, but not for insoluble. So soluble, insoluble, they are opposites. So soluble is kind of adding that mush to your poop, and then insoluble is the push. It's pushing things through. Like Olivia said, it's not digested. This is what you think of when you think of roughage, like this picture on the right here, like your raw fruits and vegetables is like my best image for this. Fruits with skins, like the skins of potatoes, whole grain products, brown rice. Like we said, every item is a mix of these foods. So you'll notice that some foods maybe cause you to go to the bathroom more consistently. Here's looking at you, corn. Like corn is just gonna push things through your digestive system. It comes out the way it went in. So if you're having more constipation, it is important to have more roughage. This is why when you have holiday parties or when you go on vacation and you're eating very few fruits or vegetables, it really helps to eat a salad when you get home.
Yeah, you're gonna crave a salad.
Is what's going to help your constipation. But we also included on here our superfood. We do not talk about superfoods because we hate that term, but prunes are in fact what we consider a superfood. One, it's an equal mix of soluble and insoluble fiber, and it also contains a natural laxative, which is sorbitol. So it is a great non-medication option for trying to manage your ongoing constipation. It's pretty similar to Miralax, but it is a food. So you can start with like one every day, and I recommend consistency all the time. And starting small. You don't want to go right to like 6 prunes because you will feel uncomfortable.
There are other foods that are also naturally high in that sorbitol component as well, but prunes are definitely the highest. I will say that like apricots, especially dried apricots, are one of my secondary like high sorbitol foods that people will incorporate. So we got to get our roughage in there. If we're having constipation, we're thinking roughage, we're thinking our salads, our stuff with skin on them, eating the apple with the skin, the potato with the skin, all that kind of thing. Okay, we cannot talk about fiber without talking about hydration because you're going to come away from this presentation and you're going to feel so inspired and you're going to have a kale salad for lunch. And if you do not at the same time as you increase your fiber, increase your fluid, you will get backed up because then you have all of this content and it's in there, but it can get dry. And that's not what we want. We need it to be well hydrated. We need your urine to be well hydrated and your poop to be well hydrated.
Just be hydrated, please.
In general, we're always shooting for that pale yellow color, thinking about the color of champagne, the color of a Sauvignon Blanc.
We didn't make that up.
We didn't make that up.
Unfortunately.
That was a urologist.
Our urologist said that and we loved it.
But like if it's
Chardonnay,
if it's Chardonnay, your things are bad. But like starting out in the morning, it's always going to be a little bit darker, but just keeping an eye throughout the day, right? Like we really want to be getting to that light yellow color at least by like midday, and trying to maintain that throughout the rest of the day as well. I'm not expecting you to be chugging water overnight because that's chaotic.
But most people, like I was doing the math out yesterday, just to give an example, is like someone who's 150 pounds, like they need roughly like 1,700 to 2,000 milliliters per day. Someone who's 200 pounds, closer to like 2,200 to 2,400 milliliters per day. So a rough estimate is like aim for 2 liters of water a day, but continue to watch your hydration. Obviously, you need more if you sweat a lot or if you have a fever or something, but in general, shooting for 2 liters is a good goal. And then if you still feel dehydrated, continue to drink water.
Yeah, I will say that a lot of people, especially with the neurogenic bladder component that goes along with the neurogenic bowel, I think in order to, one of the most effective strategies to prevent UTIs is hydration. And it goes together with the neurogenic bowel component as well. From our class, everyone always says, like, if you don't start, I think everyone that we've talked to, they're like, I get up and I have, a couple glasses of water just to get off the bat because if I get behind, then it's going to be too hard to catch up.
It's like when you get a dehydration headache. There's no coming back.
Yeah, there's no coming back. You're done.
Okay, so we mentioned one superfood, which was prunes. There is, in fact, another superfood that has recently come into play, and that is kiwis. So there was recently a study done which compared kiwis to fiber, and it had a similar effect on promoting spontaneous stooling, which, we like to have spontaneous stooling.
Yeah.
But you did have to eat 2 kiwis with the skin. And it was in fact green kiwis. We had some questions during our class about like other colored kiwis. In all honesty, if you're eating kiwis, I think you're already doing well because A, you're getting some sort of fiber, and B, like who knows, maybe it will help. So I really don't think the color matters.
No, I think that empirically people have also said like, oh, I've tried the yellow one, or what was the other one?
There was some fancy kind
Yeah,
of
there was a
kiwi,
different kind of kiwi.
remember.
But it sounds really weird. The skin is very furry. You can scrub the skin a little bit. I say cut it up. Don't if you want
Small
to
pieces.
if you want to eat it whole, then you're definitely getting more of a mouthful of fuzz, which you have to really emotionally get through. But if you cut it up and put it into a fruit salad,
You'll never know the
you'll
difference.
absolutely never know the difference at all. And they taste pretty good.
We had someone that we know that would eat a kiwi like an apple.
Yeah, that's weird. But I mean, to each their own. Live your truth.
So true.
Yeah, they were comparing the kiwis to psyllium husk, which a lot of times, like if you go to the GI doctor, they're gonna almost always tell you to take psyllium.
I can't remember if it was psyllium husk.
Yeah, it was psyllium husk. Yeah. Yeah. So kiwis and prunes, those are our 2 magic foods. I will say some people will like really dislike the taste of the prunes themselves. There is still a benefit of prune juice. However, when you're not having the whole fruit, you're not getting the fiber piece as well. But I have a number of people who will use.
So you're getting the hydration.
Yeah, you're getting the hydration. They'll use the prune juice. And they may also heat it up because that's another tip that can help to naturally move things through the system as well.
Warm liquids.
Yeah.
All right, so we talked about what to add. right? So now, or what to tweak, if you will. But there are some foods that we do need to kind of figure out, are they causing more harm than good, in terms of our bowels? Because obviously cheese is all good, but it can be constipating. What's funny is Joe is the only person we can see in our screen right now, and I know how much he loves cheese.
But he's the first to admit that cheese is not the greatest friend to his body.
True.
But there are definitely some individual triggers, and we'll mention a couple of them because we polled the group and some of our different people about like what things help them, what things hurt them. But just to kind of go through, one big thing recently is I have a lot of patients that are really trying to eat a very high protein diet.
There is a carnivore diet that is going around.
But even like not even a step below carnivore, they're just trying to get a lot of protein. And I think that a number of people have found that for them, that can be a really tough balance for their bowel program. As much as we need to make sure we're getting enough protein, we don't need to be shooting for the moon, because there's definitely a balance, and protein helps to keep us full. And we just have to take a look and like, is eating all of this protein preventing us from eating as much of those fiber containing foods or those higher water foods? Because a lot of protein foods are very low water density. They may also be a little higher in fat. And a lot of times higher fat things like the cheese can be a bit of a trigger. There's no water in cheese.
And if we look at like society as a whole, like most of us are eating enough protein, and in fact, nearly every single person is not eating enough fruits and vegetables.
Yeah, fiber is the other thing.
But we do have to consider the high FODMAP foods when we're thinking of certain fruits and vegetables and some other trigger foods. And FODMAP foods it's really just this long, intricate acronym,
yeah.
that really just stands for like foods that contain certain types of fibers that are more difficult to digest. So some things that are pretty common on there are onions, garlic, apples. Dairy foods do tend to be included there because of the lactose content. But this is where it can be helpful to like kind of write down what you eat in a day and what type of bowel habits you're having, if you're having more gas, etc. Olivia and I cannot eat raw onions for the life of us. We will die.
We will pick them out of a salad till the day that I leave this earth.
Yes.
Love the taste of them, but on their own,
so good too.
On their own, especially uncooked. Any uncooked vegetable, it has that rough edge, but it's very hard to digest. So it's going to take a lot of time, and just for both of our bodies, it's not in the cards. So it can be helpful to, we did write in here like considering like a food and symptom log. That can be helpful for, even just for yourself, just to kind of realize like, oh, I had a patient who I added this slide, but he said every time I eat pork, for some reason, it was causing a lot of constipation. So just kind of, it's really a trial and error, because as much as we have all of this different information, there are some things that there's no science for. There's only individual bodies with individual experiences.
That's why we're so cool. Humans are so cool.
They're cool and tough.
Yeah. All right. We looked at food. Now we're just going to take a brief look at medications, because we can't not. This is a whole other part of it. But remember, we're not doctors.
Yes.
So there are some interventions in terms of, what will a doctor prescribe for you? Usually that's a suppository, a laxative, a softener, or an enema. They all kind of do similar things.
Yeah, we'll go a little bit more in depth in the next slide. But also just thinking about other medications that you may have to take. A lot of medications do have GI, gastrointestinal effects as kind of like side effects, including our good friend baclofen. It's prescribed to a lot of people for managing spasticity, but it does definitely have some GI side effects. And just, the doctors are very good about kind of listing out some of those side effects and working with you to kind of titrate based on your symptoms. Metformin, which is used to manage diabetes, especially when people start on metformin, they may notice that they have a little bit of diarrhea. For some people, it goes away. For other people, it persists.
Stop it.
And then we have to make a medication change. Antibiotics, we know that those are always going to be a little bit aggressive. They're clearing out all the bugs in our system, including the good for you GI bugs that we want to be having a wonderful life in our GI system. Pain medications, like if you have to take any opioids to manage pain, those are very, very constipating.
Or even NSAID. We listed NSAIDs.
Yeah, NSAIDs can as well. Liquid medications. So if you have a tough time taking pills, the liquid formulation of medications is often it's often in like a sweetened but not with sugar formulation, and it's so highly concentrated that when people take that med, that your GI system will pool water into everything else, and then you can have some diarrhea. So unfortunately, that can be something that maybe we need to crush and put in some applesauce. Vitamins and minerals, I think the big ones we think about iron. Iron can be constipating. Calcium, a lot of people need to be taking some sort of calcium for their bone health, but especially calcium carbonate can be a little bit more constipating. I have a lot of people who have to switch to calcium citrate if they need to be on a calcium supplement. I find that that has much less of the GI side effects. It's more expensive, so people tend to buy the calcium carbonate to start.
But now you know why.
And yeah, now that's why it's more expensive. And the magnesium, everyone is so hot on magnesium. Some people maybe prescribed it for some reason, but magnesium is basically a bowel med as well. If you ever have to do a colonoscopy, they used to do magnesium citrate as the clean out process.
Just sit with that.
Yeah, just sit with that. So if you started to take magnesium, because you read online it's helpful for your sleep, blah blah blah, but you're noticing a change in your bowel habits, just maybe doing a little trial and error to see if that can be a trigger for you as well.
Okay, so we mentioned a few of the medications that are used, and we had a little star next to the laxatives, and that's because there are a few different types of laxatives, which were outlined in one of the papers that we read, and it was really helpful to kind of put a visual to it. So there's a bulking laxative. It's going to do exactly what it sounds like, and it's going to increase the stool water content to add bulk, so that your stool is softer and easier to move through your system. This is very similar to what we were talking about in terms of soluble fiber. Then there's a surfactant laxative, which allows your stool to absorb water. So it's basically working on the surface of your stool to make it easier to get softer, basically. Then there's an osmotic laxative, which, we're thinking of osmosis. It's promoting the movement of water into your GI system. And then there's a stimulant laxative, which is more working on your colon or your large intestine. So it's irritating the colon walls to stimulate the nerves to promote that contractility and the peristalsis that we talked about before. And then lastly, we threw in probiotics because what's a presentation about GI health without talking about probiotics? Olivia just mentioned that antibiotics contribute to loose stools and diarrhea because it's removing all the bugs, including the good bugs. Well, there is evidence, which we'll get into, about the positive effects of taking probiotics while you're on an antibiotic because you want to replenish that good bacteria.
Mm-hmm. So I think this is super interesting because even like I didn't necessarily fully appreciate all of the different mechanisms of action of all of the different medications that you may see. And a lot of people need a bit of a combination of a couple different ones to work best for them. But going a little bit more into the antibiotics, so a lot of people are having to take some antibiotics. We get a little UTI. Unfortunately, this is what's going to cure it most of the time. It definitely changes bowel habits significantly. Depends on the antibiotic. Some of them are less broad spectrum, and so it's a little bit less of an effect. And what's interesting is that there's been some strong evidence to recommend taking probiotics at the same time as you are taking an antibiotic as well to help with some of the GI symptoms. What's also interesting is that there is not really a huge benefit in taking probiotics outside of this time. That's based on the research, right? Each person has a little bit of an individual experience. So some people, just swear that taking a probiotic for them like totally helps them, and that's totally fine, right? Like I'm not against that. They can be really expensive though, so if someone's not necessarily having a huge positive effect of the probiotics, then it's like are we really getting the most bang for our buck here? If someone does have, like, after antibiotics, what can happen is things can get a little even more wonky. It's, kind of way past the point of a good old probiotic. We just need to always double check that we don't have our good friend C. diff.
Oh, bad friend.
Bad friend.
Bad friend.
Bad friend. Bad friend. But unfortunately, there's like not a ton of research on the specific probiotics themselves. I think that the bigger name brands, Align is one of the few ones that actually has research on it, ALIGN. And then some of the other big brands like Floristore, those ones have been, a little bit more effective. I think you can go out into a lot of different, groceries and find all kinds of niche probiotic supplements, but just the ones that actually have a little bit of research behind them. Tends to be where I direct people.
And also eat yogurt.
Yes, outside of like taking the probiotic supplement, we want to be incorporating some of those fermented foods into our daily routine. So yogurt is kind of the easiest one for a lot of people. Kefir, which is like a yogurt drink. A lot of other funky things like sauerkraut, miso, kimchi. It's a weird group. Kombucha.
Unfortunately, beer and sourdough don't count.
Yeah, beer and sourdough don't count because
it's the majority of mine.
Yeah, doesn't help with it, but it tastes great.
Okay, next we're going to talk about more of the physical recommendations, and despite all these pictures, it is not just physical activity, although I just enjoy these pictures. But there can be, like, if you have an exercise program or a standing program, like just any sort of extra movement can help stimulate the peristalsis and the movement of your GI system. You can also kind of massage your abdomen too. So we'll have some people who like your large intestines you can't see, but it comes like up the right side, over, and then down the left side. So you can kind of do a massage to promote the contractility. You can also lie on your left side. We have people do that in the hospital setting when they're doing bed level bowel program, because that can be helpful. But also a seated bowel program if you are able, because gravity.
Yep, gravity helps.
Helpful. And then digital stimulation is also a physical recommendation, especially for people with the more flaccid type of neurogenic bowel, because they don't have that like tightness of the anal sphincter.
All right. Think about the time that you're doing your bowel program as well. Like we mentioned before, what time were you used to having a bowel movement throughout the day? There is actually an increase in natural peristalsis, so that like natural movement in the morning. So a lot of people do end up finding that the morning program is most effective. Peristalsis is triggered by eating and drinking. So having a little bit of a small snack prior to doing your bowel program can help to naturally kind of move things along, especially a small snack that includes a warm beverage. So like if you have, tea or coffee, there is a natural stimulation from caffeine as well. Hot water, warm prune juice, warm milk, all of those.
Especially if you're lactose
If you're lactose intolerant, yeah, the warm milk really get things going. But just trying to work with as many of like the natural things that we know are happening in our GI system as possible to just avoid having to use so many different medications and just make our program as effective as possible.
All right, so how do you know when it's done, right? So if you've done 2 ditch stims, if you do ditch stim and no stool has come out, at least 10 minutes apart, it's probably the end. If mucus is coming out without stool, sorry. That's kind of like when you think about like when you have the stomach bug and you're throwing up, but like nothing's coming out, it's just mucusy. There's nothing left. There's nothing in there. Or if your rectum just feels completely closed and feels tight, then you should know that it's the end. And obviously over time, once you know more about your program, your body, this will become easier to tell.
Mm-hmm. All right, so this is obviously the very, very last resort, but we had a really good GI talk a couple years ago with a doctor and then some patients, kind of to talk about their individual experience with bowel program. And, there are definitely some individuals who try every single thing on God's green earth and truly nothing is effective, and your bowel program is basically ruling your life, right? And that's
Not the point.
not really the goal here. And there are options, this is our most drastic of options, but they're still there, right? And for a lot of people, once they do pursue this, they find that it can really, open up a lot of their life. A lot of times, the first one that we think about is a colostomy, which is basically where we create a stoma, which is an opening. One patient called it a poop hole.
It's accurate.
The other day, which is what it is. Create an opening from your colon to your skin, so like kind of moving into that connection with your anus out into your belly. And so you're not using your rectum to defecate at all. You have the opening and you attach a bag to it throughout the day, and the stool goes right in there. It definitely increases independence. We're really decreasing that fear of incontinence. There's definitely some diet changes because there are certain things that just, put us a little bit more at risk for a blockage. Corn, unfortunately, that's kind of the biggest one.
Ugh, popcorn.
Yeah, popcorn. And it is still a surgery with potential complications. So, I think that anyone who does decide to go through with this, doesn't go through with it lightly. There's a lot of things that go into this discussion, but I think I have some patients who I feel like would benefit from it, but they're just not quite ready to cross that bridge, unfortunately. This one is so fascinating. I think it's so cool. They do it more often in kids, especially kids with spina bifida, because it's a lot easier for a parent to manage. But you create another stoma, so you take your appendix and it connects to your skin, usually through your belly button, very discreet. And then you can use that opening to flush a solution. So you're basically doing like a backwards enema. Because normally you would do an enema whereby you would insert some liquid into your colon and then things would come back out. This, you're kind of putting stuff into the colon and it's moving through along with the fluid. What's really interesting is that it's like super effective. There's a very low complication rate, and you can do it as much as you need. So like you can run the solution twice a day, 3 times a day, like whatever needs to happen. I just found it was so fascinating, especially that they use the appendix
And the belly button.
and the belly button.
Why not?
2 useless things in our body that we're not putting into
That are not useful.
to great use.
So we threw a slide in here too, because we've talked about a lot of these interventions about what you can do in terms of diet, movement, etc. But there was a great study that we reviewed a few years ago that just talks about like some of the barriers to making some of these healthier choices for people with neurologic conditions who like either have to rely on caregivers or who are also just like adapting to like these huge changes in your life. So, we can't go about this lightly. Like it is really important to look at where people are coming from pre-injury or pre stages of change, if you will. If people are bored or if they have really significant changes in their appetite or fatigue or even just difficulty relying on other people. So it is an all-inclusive process.
Yeah, it's a lot. It's a lot of things to manage. It's kind of oftentimes the biggest trouble for people is the bowel and the bladder. All right, so shout out to our clinical pearls from individuals with spinal cord injury. People may notice some things
That they told us.
that they told us. Okay, so I would say food things that maybe are triggering or helpful for people. So like corn is such an interesting one because you will see it.
You want to know how long it takes to
Yep.
move from point A to point B?
Yep, corn will show you how far and how
Eat the
long.
corn.
Like I was mentioning, I had a patient that was like, every time I eat pork, for some reason I'm getting so constipated. But then he finds that if he has pork, then he needs to eat 2 salads that day.
Oh, yikes.
And that is what he needs to do. But you know what? He figured it out. A lot of people will use the snack in bed because like if you're doing a
Mhm.
morning bowel program, kind of a lot of people like get up and get moving. But if you can keep some dried apricots, maybe a prune or two next to your bed, kind of naturally get things going because then you're using like the morning time with the natural increase in peristalsis. You're using the food to kind of help naturally move things through as well. Um, Dried fruit is definitely a big one that helps a lot of people. I think dried specifically because it is so concentrated that your body will naturally try and pool a lot of liquid to dilute it. With any of these changes, like you definitely don't want to be going from 0 to like 5 kale salads a day.
Or 0 to bean soup.
Yeah, 0 to bean soup is a
Oh,
big progression. But beans are definitely a magical food. Very high in fiber. They get you some protein. They can be made so many different ways. And I
It's a
spent,
bean soup. You've got the hydration.
yeah, the hydration. Soup is a great way to get lots of different vegetables in there.
Dark beer, probably not as healthy of an option, but it can do the trick. Any type of beer actually can be helpful, but dark more so. But then there's also some of those like more constipating things like cheese, bananas, oatmeal. So definitely being preventative and proactive, thinking about what works for you, starting slow. But then some of the more positioning things, we've had people mention like using a seatbelt for abdominal pressure, using your hands or your arms for abdominal pressure, deep breathing, decreasing stress because stress can cause a little more tension,
Yeah.
or massage like we talked about.
Okay, so how do we pull this all together? So neurogenic bowel occurs in a variety of different conditions. It is managed with a consistently timed bowel emptying protocol, or what we consider a bowel program, BPG, in the doctor's notes. There are a variety of different strategies that you can use. And nutrition is one of the like lowest hanging fruits, right? Like worst comes to worst, you eat something, it bothers your stomach, it's out of your system in like a day or so. Um, we can make a lot more changes without having a ton of risk. Our body knows what to do with foods a lot better than what to do with a lot of other things we have to put into it. So it's a good place to start making some changes.
Food first.
Yeah. All right.
Yeah. Wow. Thank you so much.